Thank you all for coming today and spending your time here so that I can share with you some tips that we have in general for patients who are going through cancer therapy. So like Darla mentioned, I'm a dermatologist here at Stanford, and I have a special interest in taking care of the skin needs that occur in patients who are undergoing cancer therapy. So that's what I spend all of my time doing in the clinics, is just taking a look and helping people navigate through their skin issues that arise through cancer therapy. Sometimes it's due to the therapy itself. Sometimes it's due to a different medication that's that's used because of a side effect of a therapy. Sometimes it's due to infection because of the therapy. So we just want to help our patients in this journey, help you guys in this journey as you go through your cancer therapy. So what I wanted to focus on today was just kind of two broad skin conditions and skin issues that come up for all patients who are going through cancer therapy, and that's kind of dry skin and how to protect the skin from the sun. I think they're very practical tips that we'd love to share, and I hope to spend the next kind of few minutes talking about that today. So skin changes are very common during cancer therapy, and this is for many reasons. We'll go into that in the next slide. One is that just the skin is a rapidly proliferating organ. It's a cell that continues to renew itself very quickly, and because it shares that similarity with cancer cells, many therapies that target these rapidly proliferating cancer cells will also target the skin, and therefore we see sometimes worsening of someone's skin condition that they may have even had going into therapy. So someone with very dry skin might have even more dry skin. Someone with eczema might have exacerbation of their eczema. So we oftentimes see that when someone's undergoing a treatment course for their cancer, they can get worsening of any of the skin reactions they have that have already been present. Some treatments themselves can cause patients to have itchy skin. Some patients can develop a rash due to their treatments. And the two main areas of focus today I wanted to spend time on was dry skin. So again, sometimes due to the treatment itself, sometimes due to just having less time when you're going through all this therapy. You're more dehydrated, you're busy coordinating all of your visits, so it's just literally less time to take care of the moisturizing of the skin can happen, leading to more dry skin. And some treatments may cause a patient to be more sensitive to the sun's UV rays, leading to increased risk of sunburn. So we definitely want to make sure we prevent that and protect patients from that. So one plug I want to make is Mario Lacouture is a mentor and a leader in this field, and has this wonderful guide and book for patients, and it's designed for patients, and the language used is so helpful for patients and caregivers. And I have a copy here if anyone wants to take a look at it, but it has wonderful pearls and tips for just any question that might arise as you're going through cancer therapy that has to do with how to take care of the skin, what to do if you might see a certain type of rash. And this is on the right, just one example from one page of this book where he talks a little bit about why the skin has so many problems when patients are going through cancer therapy. And like I mentioned before, a lot of it is due to the fact that the skin is proliferating more rapidly and restoring itself rapidly. And because of that, many cancer therapies target that same type of fast replication, and that's why we see some issues in the skin. And this is a nice diagram in the book showing just for our purpose here, the three layers of the skin, the epidermis being the top layer of our skin, which is the protective barrier. The skin is the biggest organ in the body, and it's got the epidermis that really protects us from outside infections, outside irritants, but also protects all of the moisture and fluid and everything that's inside our bodies from escaping as well. So it's a very, very important barrier there. And this is just another more scientific looking diagram of the layers of the skin, and I just wanted to very quickly talk about the epidermis. Again, that's the outermost layer of the skin, important barrier protection, and when that's lost, we see more issues such as itching, peeling, dry skin, infections, many things can happen. And then we've got the dermis under that contains nerves, which can be, if they're irritated, can lead to sensations in the skin that are very disturbing to the quality of life. We have our immune cells and blood vessels that provide a very important kind of infection control and nutrients. and bring all the nutrition to the skin.
And I hope not to be too long.
Yeah, no worries, welcome. And then also contains structures that are very important for flexibility, the malleability of our skin. Okay. So I know all of you in this room are probably going through or have family members or friends who might be going through different types of chemotherapy or cancer therapy, and they can be so variable, and not even on this list isn't even radiation, but that can cause skin change as well. But I like to think of the therapies that patients are going through and put them into broad categories. And some of you here, we just spoke with some here, might be going through cytotoxic therapy. So these are kind of our classic chemotherapies that kind of destroy all types of cells that are replicating faster. They don't distinguish cancer from healthy cells, and many of patients who are going through these will get scaly, red, dry, peeling skin, oftentimes on the hands and feet. They'll lose their hair, they'll develop mouth sores. So when we understand your therapy, we kind of can understand what skin conditions can occur during treatment. Some of you may be going through targeted therapy, and these are therapies that interact and disrupt the activity of specific molecules in pathways that are involved in cancer cells, and we can see very, very specific skin reactions there. And some patients, some of you may be going through immunotherapy, and this is when the cancer therapy is being used to unleash and stimulate the body's own immune system to try to fight the cancer. And we see a lot of inflammatory or autoimmune skin eruptions with these therapies. For all of these, the things that we're going to talk about, apply dry skin care, moisturizing, and sun protection, is relevant to patients who are getting treated with any of these therapies here. But I wanted to share this to just kind of go through how we like to, in dermatology, think about a patient's skin when they're coming in. We like to think about what are they receiving and how could that potentially be impacting the skin, and then how can we more efficiently help them with their skin. So dry skin, the fancy word for that is xerosis that we use, and for some people it's not a big deal, but for many it can cause quite a bit of debilitating quality of life issues. It can be very uncomfortable, especially if it gets very bad, and it can become quite severe in the setting of getting cancer therapy. If it's very severe, it can lead to quite a bit of itching and pruritus, and this definitely can impact quality of life. When it's even more severe, you actually get a breakdown of the barrier of the skin, which is so important, like we talked about earlier, which can lead to infection because we've lost that protection against the outside environment. It can lead to inflammation, so inflammation of the skin because the skin is now more irritated. That can cause these itchy red rashes. And then it can cause fluid loss due to us, again, losing that barrier that was protecting even the inside, the very important nutrients and fluids that are in our body. All these things can happen, and they all start with dry skin, and this is why dry skin is so important to take care of during cancer therapy. Another reason it's important is that every time we bathe or expose our skin to water, that includes hand washing, bathing, that's stripping away moisturizing oils in the skin, which can lead to more dry skin. And this is important in the cancer patient because we're washing our hands a lot, right? So patients are washing their hands. We're wanting to stay away from infection and stave off infection as much as possible. And one of the things that we see in our clinic so much is that patients are washing their hands so much appropriately that they're actually causing so much dry skin. We're getting cracking in the skin, and then we get a devastating infection. And that just breaks my heart. I just think, gosh, everybody's working so hard to keep away from infection, but we're actually making ourselves more at risk in some way. So we want to definitely share tips for how do we still have that meaningful wash. We know why we're all washing. We all want to prevent infection, but how do we make it meaningful so that we're not contributing to another source of potential infection? And really the big take-home tip is that I like to tell our patients, after any water exposure, whether that be washing the hands or giving your son or daughter the bath or helping someone with something, or any shower, the moisturization needs to happen immediately, within 1 minute of that water exposure. So that's easier said than done. So the next step is, how do we make that practical? How do I make that a reality? So, and again, I want to emphasize the importance of this after every hand wash, because the showers and the baths we can kind of control. If we have our moisturizer right there, we are really good about getting the moisturizer on the body within a minute. But the hand washing, it happens when you're visiting the doctor in the clinic. It happens when you're at the restaurant eating lunch. It happens after washing dishes. It's happening so many times throughout the day. So what we do is we counsel our patients to get a hand moisturizer or a cream. We'll go through some of the products we like to use and have that. We have to make it practical and make it real so it doesn't take extra step or thought. And you just want to have a moisturizer at every single sink that you have in your home or wherever you are visiting. And you want to have it in your purse, in your bag, in your spouse, in your partner's purse, so that anywhere you go, you have that without needing to walk to another room. You have that opportunity to moisturize and seal in that moisture. And that is how we're going to make the hand wash more meaningful. So we're going to wash so we prevent infection, but then if we moisturize, that really makes that wash very meaningful because we haven't led to dryness and cracking that would be a separate cause for infection there. And then I also tell our patients too that we don't want to forget to moisturize even the tops of the nails at the cuticle. So the cuticle is a very important barrier that protects where the nail is formed from. It's a seal there that protects infection from coming in. And if we kind of moisturize here but we forget the cuticles, and the cuticle gets broken, it gets dry, and then we get infections around the nail there very commonly in patients. So just washing but making sure that we're even moisturizing the tops of the nails at the cuticle is very important. Obviously, we want to protect our hands during any wet work with gloves. So wet work including kind of washing dishes or gardening, it's very important to have the gloves on. We want to use gentle soaps, so I like to stay away from antibacterial soaps because those can strip quite a bit, but sometimes those are appropriate to use too. Just want to make sure that we moisturize. And then this last one is choosing the correct vehicle. I'll go into what that means, but when you walk into CVS or Walgreens, you see hundreds, if not thousands, of different lotions. It's so intimidating, and I think that is what limits so many people from doing it right too. So we want to just simplify that all too. But the vehicle is kind of, what is it? Is it a gel? Is it a cream? Is it a lotion? Is it an ointment? Does it matter? How do we choose that? So I'm hoping that the next few slides will help us in a practical way decide. So vehicle that we moisturize with is important. So again, like I said, things come in gels, lotions, creams, foam, spray, ointments. What do we recommend? What's the most high yield and what's the most realistic? So in general, ointments, so things that are called ointments, which are 80% oil and 20% water, are going to do a better job at moisturizing your skin than a cream, which is 50% oil, 50% water. And then that's going to do a better job than a lotion. So a lotion has quite a bit of high water content, so we're losing the ability to moisturize. So in an ideal world, the best moisturizer that you would use would be in an ointment form. However, the practicality of having something really greasy on the hands when you're trying to do all the life things is not always feasible. So creams are kind of somewhere in between where you're going to get good moisturizing, but not at the expense of it being impractical and leaving kind of fingerprints everywhere you go, or soiling all your clothes. So ointments and creams tend to come in jars. We can look at the labels themselves, and as long as it says cream or ointment, then that's going to be probably the most preferred vehicle for the type of over-the-counter moisturizer that you pick in order to get the best kind of emoliation that you could have. Now, I put a note here about if there is a rash or broken skin. Many patients stop moisturizing because their lotion or their cream suddenly burns when they put it on. It hurts, it stings. And that's because anything that is outside of an ointment requires preservatives to keep it in its state. So the creams and lotions require preservatives, and those can be very irritating. They can burn and sting the skin when it's applied to broken skin. So in patients who have rash or burning of their skin or any broken skin, we highly recommend, at least until we can repair the skin, using ointments, because it'll be soothing. They won't burn until we can get the skin to feel better. Now, what are some examples of ointments? They're my personal favorite, although I don't like to recommend brands too much, but it's just plain petroleum jelly. So Vaseline is the most common brand, but Walmart sells Equate brand, probably a couple dollars cheaper. There's no benefit of getting name brand versus other. In our clinics, we often use that bottom tube down there of petroleum jelly. So this is going to be, it won't burn your skin, and it's going to provide you with the highest level of moisturizer. Many of our patients, when they have very dry, cracked hands, we advise them to use ointments in the evening, right before bedtime, so that it's okay that it's messy. They don't need to do computer work or phone work during that time. So it's a great time to get that heavy ointment. Many patients love Aquaphor. It smooths on a little bit more elegantly than the petroleum jelly. I put a caution there about lanolin because Aquaphor contains something called lanolin, which is quite soothing, but in a small fraction of patients, they can develop an allergic reaction to that. And sometimes we run into patients who are moisturizing with Aquaphor over and over, and they're not getting better. In fact, they're getting more itchy, and we discover that they have an allergic reaction to lanolin. So I just put a small word of caution out there. There's no necessary need to use it, although it does. Many patients do love it, and it works fine. But if someone's using Aquaphor and they're not getting better, one thing to think about is maybe they have an allergic reaction to this small component of it. So I personally think petroleum jelly does the job. Don't need to be any more fancy than that when it comes to ointments. Yes.
Is that a petroleum product too?
Yeah, so it's a base of petroleum. So I think you get everything that you would need, and then you just don't need much more than that. So when you're looking for lotions and creams too, there's no need to buy the ones that have fancy aloe, vitamin E. Those are all additional items that could potentially cause irritation. Just the purest, most bland emoliator you can get is the petroleum jelly, and most of these other things are all made with that, with added things on top of it. So the ointment, the petroleum jelly is the way to go. Yes.
So weight or Vaseline, which is like the same petroleum jelly, but they put it under the Walmart brand.
Yeah.
There's a kind of ointment that is fat-based versus the other creams that we get from fancy creams are water-based. So they absorb fast and they feel happier. Oh, okay, I don't have all this fat or grease on my hand. But actually, this one would do the job even, or could be even better, and we don't really need to run after names, right?
Right, we don't have to run.
Do it.
Yeah, this is going to be because the ointments are 80% oil, 20% water, so they have more of the oil, exactly like you said, than water content. They're going to be the more effective and efficient moisturizer for you. Then kind of like you said, the efficient or the moisturizing versus practicality. So it's not as realistic for patients to have Vaseline all over their hands through the day. So that's where we do recommend creams sometimes. So it's just kind of whatever works. We want to give patients kind of all the different options so that we can kind of pick and choose what works at this day, this part of my life, this stage of my life now.
Aquaphor, where do you find it, and what extra it does have?
What was that? Where?
Aquaphor.
Yeah, where do you find it? You can get it at CVS, Walgreens, any kind of pharmacy store or
department. Has on top of.
What does it have in addition to Vaseline? So it has something called lanolin, which so some patients prefer Aquaphor because they feel like it goes on a little bit more elegantly, less messy than petroleum jelly. And it works very well for many, many patients, but occasionally, every once in a while, someone has an allergic reaction to lanolin, which is a component in Aquaphor. So I have patients start with petroleum jelly, and if they want to use Aquaphor later, they can. It costs a little bit more too, so there's really no need, in my opinion, to go there. However, if someone won't use the petroleum jelly because of the way it feels, then it's okay to try Aquaphor and just watch out for that allergic reaction. Yes?
Sorry, I know you're on ointments. Would grapeseed oil, castor oil, would that fall into this same category?
Yeah, so those are great thoughts. So many of our patients want to kind of use the most pure emoliators, and so many patients use coconut oil, and I think that's been the biggest one. There's been some recent studies looking at the ability to moisturize with many different oils, and I don't have all that data off the top of my head, but I'm so happy to look it up after this so I can share with you guys, and that gives this feeling of a natural product that someone can feel comfortable using. So I'm happy to I should learn it myself again and have it fresh in my mind, but I'll share with you guys just kind of in order which one of these natural oils would be the most effective in terms of moisturizing. Thank you for that question. Okay, so then now cream. So these are more realistic, right? So we're about 50% oil, 50% water here. They're still going to be better than our lotions. And this is definitely not an exhaustive list of what can be used here. This is just kind of the most talked about brands that I've used at home that our patients have shared with us. I want to highlight this hand cream. It's one of many of our patients use it. This Neutrogena hand cream, it's one that they like to carry. It's easy to get, and they just have it at every one of their sinks, but really there's no reason not to get any of these. Many of our patients have a jar of every one of these, any one of these at all of their sinks. We have it in my own home in every single bathroom, in every at every sink, so that we can just all have that meaningful shower, and then moisturizer, hand wash, moisturizer. We used to tell patients just as long as you can identify a cream because it doesn't have a pump on it, right? It doesn't have that lotion pump, but actually Vanicream, CeraVe, and Cetaphil all have made their creams with the pumps. Now it still comes in a jar, so don't be afraid of the pump sign, but just look for that word cream, and this is gonna be the more practical day-to-day multiple use moisturizer. And if you can do Vaseline or petroleum jelly, that's wonderful, but if we need something kind of more lightweight that still will do the job, this is the way to go, especially for the whole body. Okay, any questions about, yes?
Actually, I have a question regarding radiation.
Yes.
So for radiation, these creams, are we the ones also, or we need more?
Yeah, that's a great question. So I'm going to repeat the question. So the question about radiation, what do we use? So I think in radiation, the skin tends to be irritated. So if there's redness or broken skin, I would stick to ointments because otherwise we're going to have that burning sensation from the preservatives of a cream. If the skin's not broken, the creams are fine, but I would say that for the patients that we see with radiation dermatitis, we do recommend petroleum jelly. At that time, it's going to be the least irritating and burning to the skin and the most soothing at the time. Yeah, also petroleum jelly.
Do the same top.
Yep,
For
yes.
that top treatment.
As a moisturizer.
I heard about a lady buying creams for $45 on Amazon.
Yeah, yeah.
For 7 ounce.
Right, right.
There's a lady, I think it's called Jean's Cream.
Yeah, yeah.
There's a lady who created
There's-
that after she was
right.
herself exposed to
There's many
radiation.
different
So
creams.
do we need to go that far?
I think, there's so many of those formulations, they have their own benefit. It's kind of like the Aquaphor comparison. I think there's a reason why there's been a new formulation because there's certain benefits of it. It goes on better, it feels soothing. There might be even added soothingness to it, but they all come at the expense of a potential irritation. So, and not every patient will have that, so it's not wrong to try some of these, but the patient might be that one that develops the allergic reaction or that irritation from that extra product that's in there. So I love to start simple and straightforward and accessible, and then we can always ramp up or move or change gears if it's not doing the job. So
And you recommend starting this kind of stuff before radiation?
I think it's good to take care of any dry skin before radiation or any cancer therapy, absolutely. Right, and it doesn't mean this is the only thing that's used to treat radiation dermatitis. If there's infection, if there's inflammation, then we would talk about prescription treatments as well. Okay, sure. Okay, and then what comes up too is because dry skin itches, I think many of our patients go out and they tend to go straight toward the lotion for anti-itch or the lotion for this, and so I wanted to spend some time talking about that today too. So the topical creams and lotions that are used to treat itch may not necessarily be the best moisturizers. So we still want to think about those ointments and those creams as our moisturizers, but definitely these products such as Sarna, CeraVe Itch Relief can provide a lot of immediate comfort when patients have itchy skin. Again, they tend not to be good moisturizers, so we still want to make sure they have a great moisturizer, but they can provide symptomatic relief of itch because they contain, Sarna contains menthol and camphor, and the CeraVe Itch Relief contains pramoxine. And these, the skin is not smart enough to feel more than one sensation at a time. It knows how to feel itch or pain or heat or cold. So these ingredients, in a sense, trick the skin. So instead of feeling itch, it tricks the skin into feeling cool. At that time, it provides some instant relief. So these are very helpful for our patients who are having just debilitating itch to get some instant relief, and they're safe enough to use multiple times a day. Many of our patients go out and buy Benadryl cream because you just think Benadryl itching, and it can be helpful in some cases, but it's another thing just like the lanolin where there's a higher risk of developing an allergic or irritation reaction to that component, which we like to avoid. So if it helps and there's no irritation, that's fine, but just keep in the back of our minds that there's that possibility. So we still stick to the Sarna and CeraVe Itch Relief. Okay. And then finally, there are these keratolytics. So some patients who are going through cancer therapy will not just have dry skin, but their skin will be dry and very thick and scaly, especially the hands and the feet. So there are products out there, prescription and over-the-counter, these are all over-the-counter here, that actually have enzymes that kind of eat away, or acids that eat away at thick skin. So obviously we wouldn't want to use this on very delicate, thin skin on the face where this could be irritating. But on the hands and feet, if it's very dry, we sometimes have our patients go out and purchase lactin or lachydrin or urea creams, and that can help to smooth out very, very scaly, dry skin, and it can be a good addition to the moisturizers that they use. Okay, so any questions?
Yes. About triamcinolone?
Triamcinolone? Yeah, so the question is, what do I think about triamcinolone? So that's a mid-potency topical steroid that we definitely use to treat inflammation. So if there's inflammation driving any symptoms or problems in the skin, we tend to prescribe topical steroids, which can reduce the inflammation. We want to be careful to use it in the right locations of the body and under the right circumstances. So if there's no inflammation, or if we use it in the incorrect part of the body, it can lead to skin thinning and skin breakage, skin infection, and acne in the skin over time. So it just needs to be used in the right situation for the right
So it doesn't contradict with the treatment of cancer.
It doesn't. It should.
I'm taking chemo now.
Right.
But
Right.
at the same time, I used to take triamcinolone.
Yeah.
No more than 2 weeks because it's going
Right.
to cause thinning.
Right. Right.
But right now, is it okay to use?
Yeah, so definitely we like to run everything by your oncologist. So is it okay to use triamcinolone during chemotherapy? Definitely. There are some clinical trials that where we have to be very careful with what medications we use and what time. So I think, as with any prescription medication or any medication that is ingested, I always just like to run it by your oncologist to get that blessing to make sure it's okay. But yeah, it's a wonderful medication. I would say it's our probably the most common thing that we prescribe from our clinic. But again, we just want to use it for the appropriate diagnoses in the right locations and for the appropriate time. Okay, any other questions about dry skin? Okay, great. So then now to sun protection. So why is it talked about so much when patients are going through cancer therapy? I think one is that many cancer therapies or the medications that you might be getting while you're getting cancer therapy, such as antibiotics or other medications, can make you more susceptible to sunburns or UV radiation. And we don't want to add that complication to the whole list of things that are going on when someone's going through cancer therapy. So just some practical tips of what do we do to protect ourselves from the sun. I think one thing I want to really emphasize before we even go to the tips about how to protect is that when people come to our clinic, we have some patients who say, I've just been camped out like in a cave of my home for the last year because I'm so afraid of the sun because I was told not to go out into the sun. And I think that's not what I want to share today. I want to share that we should all, as much as you possibly can, do the things that you want in your life, even if that means it's outdoors on a boat or on a beach in Hawaii, but we can do it in a safe way, and we can do it in a way that is protecting you from the sun. So it might take more effort and be a little bit more higher maintenance, but it doesn't mean that we have to tell all of our patients that you need to just hide in the shade all the time. So we want you to be empowered to go and live life, but teach you the tools to do it safely. So one is limiting sun exposure, meaning, again, if there's the option to go swimming at 11 a.m. versus 5 p.m. and it would feel just as fulfilling, then I would choose 5 p.m. over 11 a.m. when the sun is at its peak. So just knowing that the sun exposure is at its peak between 10 to 2, 10 to 4 every day is just a helpful tip in kind of sometimes trying to choose when to time certain activities. And then sun protective clothing is something I want to spend some time talking about and demonstrating, because I think it's a very practical and efficient and cost-effective and an environmentally friendly way to protect ourselves from the sun. And finally, we'll go through sunscreen, which all of us probably know about, we probably use. I think I'm going to talk about it again. The key to sunscreen is getting enough on and reapplying, otherwise we lose the benefit of it. So first, sun protective clothing. This is my 3 kids on a beach in Hawaii, and actually someone came up to us that summer or that spring break and said, do they all have diseases? Because they're wondering why they're so covered up. But this is what happens when you grow up with a dermatologist mom. But I think I'm hoping, and we wish, that when we're on the beaches or we're outdoors, that we see everybody like this, because there's so many benefits from protecting from the sun. We prevent sunburn, we prevent skin cancer. If you're on a medication that could make you more prone to getting sunburn, it's just devastating to get that type of sunburn. Those sunburns last for a long, long time, and they can cause pigmentation and changes in the skin that last an even longer time, sometimes even years, and it just serves as these reminders of the therapy that someone's gone to. So I think we just want to emphasize how important it is to protect from the sun. And then on top of that, there's benefits of just decreasing aging. So the UV rays also contribute to aging. So the more we change our lifestyles to protect from the sun, the younger we'll look in 30, 40, 50 years. So there's multiple benefits from sun protection. So sun protective clothing, the reason we recommend it is cost effective, and then it's also even less labor intensive. If you've got the hat and you've got a sun covering or some long sleeved element on, you're not going to need to reapply that sunscreen over your scalp, your arms, your trunk again every 2 hours or every 40 to 60 minutes if you're in the water. So it just saves a lot of time. It saves a lot of money that is being spent on sunscreen, which is not very cheap. Environmentally beneficial too, because it can be reused over and over again. So this is through hats, long sleeve swimwear, and there's some brands, it's not exhaustive, but these are just some brands that can that make a lot of kind of water friendly type things. But really honestly, if you have a long sleeve shirt on, if you're not going in the water, if you have your regular long sleeve shirt on, you don't need to buy an SPF or UPF shirt. That's going to provide you sun protection. So I like to say everywhere that's covered in clothing doesn't need sunscreen on top of it, and so we limit our sunscreen use to where the skin is exposed and not covered. Okay, and yes?
How strong do you recommend the sunscreen?
Oh, very great question. Yeah, how strong do we recommend the sunscreen? So I'm going to go into that in the next few slides about SPF and all of that. So another practical tip about sunscreen is, again, we have to reapply. So we like our patients to kind of get into that habit of using sunscreen every morning, because once you build a habit like brushing teeth, then you don't think about it, then you don't miss that one day. UV radiation penetrates through rainy, cloudy days. So even today, rainy and cloudy, we've got UV coming through car glass windows, we have UVA. So just thinking just because it's cold, it's because it's winter, I'm not getting UV, is a misconception. We've seen many patients get pretty severe sunburns, even in the dark of the winter, when they're on a photosensitizing anti-cancer therapy. So it's just good to get in that habit of using sunscreen every day. If you're outdoors hiking at the beach or anywhere that you're exposed to outside, it needs to be reapplied every 2 hours and every 40 to 80 minutes if there's water exposure. We don't want to forget the lips, because the lips, especially the bottom lip, sits like a shelf out for the sun to hit. So you can get chapstick or even Aquaphor. Many sunscreens come on as a chapstick with SPF. Makeup containing sunscreen is a very helpful and efficient way to get sunscreen on in the morning for many of our female patients who put on makeup in the morning, so their foundation or their powders can have SPF in them. And then this is where the practicality comes in. How do we pick which one? There's so many brands, there's so many different types. To me, the brand doesn't matter. It's all about choosing the cheapest sunscreen that you feel comfortable using, that the smell doesn't annoy you, that the way it goes on doesn't burn your skin, that the way it looks shiny doesn't bother you. So the brand doesn't matter. It's just finding one that feels comfortable using and that fits economically into the budget. So what do we look for? So are there sunscreens we shouldn't use? So as long as the sunscreen says broad spectrum, then we're okay. And broad spectrum means it protects from both UVA and UVB. And in 2011, the FDA passed a rule that it can only be labeled broad spectrum if it provides UVA and UVB protection. So as long as you see the words broad spectrum on the sunscreen, you're going to be okay. And I would say the majority of what you can find will all say broad spectrum, but that's the word you want to look for. And then how strong? SPF. So that's what we're going to get into. SPF, what does that even mean? It means how much protection does the sunscreen provide you? So if you were going to have a sunburn at this many minutes, the higher the SPF, the higher the multiple of how many more minutes you technically could be in the sun until you get a sunburn would be. That being said, there has never been any data to show that any SPF over 50 leads to any improved effectiveness of sunscreen. So We personally, actually at SPF 15 is all that's really needed, but patients usually don't put enough on it to truly get SPF 15. So to be safe, I personally recommend getting SPF 30. No need to go above, and that way if we're not putting on enough on, at least we have that little buffer of cushion there. Now, if we go above SPF 30, we start getting into more costs. It tends to be more expensive, so patients tend to use less of it because they're not buying as much. And also there's this feeling of invincibility. So patients who are using SPF 100 might feel like, oh, I feel really protected. I'm going to spend more time in the sun or not reapply as much, even though there's no data that that's providing much more sun protection. So that's the reasons we don't, if you have SPF 90 or 100 at home, it's fine to use, but there's really no benefit or need to spend the extra money purchasing anything more than SPF 30. Yes?
I understand there is a way to verify what the manufacturer says is their SPF level versus what is really, there's a testing. Do you remember the name of the website you can go to look and say, how do you pick this up? Sally Mae's SPF 50, and you find out the website you can go to and say, oh, but Sally Mae isn't really 50, it's really 25.
Oh, because based on what patients are using. You know, I actually am not familiar with that, so I will look that up. So it's based on maybe people's real experience or other testing, huh?
There's like a consumer report, I
Yeah.
would say this, a consumer, but
Yeah.
someone actually did
Yeah.
the evaluation and found out that most of the things are mislabeled.
Yeah.
And so you need
Wow.
to make sure.
Right.
I'm like, well, where's the website?
Right.
What's the
Right.
website? So.
Yeah. So I know the Environmental Working Group makes some. They make some recommendations, or they make some comments on sunscreens. But that's something I'll look up, and I'm happy to share with everybody. Yep. And now there are kind of neat tools that there are certain stickers that patients can buy where you can put your sunscreen over it, and then it changes to certain colors, and then you kind of know when to reapply because so they have tools like that now. A lot of times they're marketed toward children, but it's something that you can put on your shirt and you can put the same amount of sunscreen that you would put on your body, and it gives you kind of an indicator of, oh, when is it time to reapply? When have I been in the water enough that it's washed off? So that might be another tool too, to just kind of give you a good idea of when we need to reapply, because so much of it also depends on just what's happening. Are we sweating a lot if we wiped down quite a bit? Okay, and then this is a big question for many of our patients. So our final slide is, so not just sunscreen, which brand or which SPF, but what kind. There's all sorts of different, there's children's sunscreen, there's chemical blockers, there's physical blockers. What do we use, and is one better than the other? And I think there's not any, one is not necessarily better than the other, but there's just different times or reasons we might use one versus another. So chemical blockers, these tend to be the most popular sunscreens, especially for adults, because they tend to blend in and they go on very elegantly, so they don't leave that white pasty film on the skin. And how they work is they absorb UV radiation within a specific wavelength, and this decreases the amount of UV radiation that then goes through that epidermis, that barrier layer of our skin. I would say that in our cancer patients who are going through therapy, we tend to, oftentimes we'll have to steer away from chemical blockers if they have a rash, because they're having a rash that's being triggered by the photosensitivity from the cancer therapy. And when they use a chemical blocker, it can sting the skin because of the chemicals in it. So some of our patients, this just isn't an option, especially if there's an active rash that we're trying to sun protect. Doesn't mean that it's dangerous, but it's like kind of like using a cream on it. It just burns the skin, so it's just not practical or realistic to get it. And that's why I want to talk about physical blockers. So these will contain the ingredients zinc oxide or titanium dioxide, or sometimes both together. And instead of absorbing UV radiation, these are kind of they're small metals that just literally coat the skin, and they reflect or scatter the UV radiation away from the skin. And this is what tends to be the active ingredient in children's sunscreens, because children, when they get the chemical blockers in their eyes, they scream, they complain about that, so the physical blockers don't irritate as much. So for our patients who come in who have an active rash or broken skin, I oftentimes recommend a physical blocker, because during at least that acute time that they're trying to get their skin better, that's going to be more soothing. It's not going to cause that burning that the chemical might cause. But then it's harder to get it to go in more elegantly, because they tend to be, zinc oxide and titanium dioxide are very pasty and white. That being said, there are companies now that are making more elegant forms of micronized zinc or titanium dioxide that do smooth in. I personally am using a physical blocker today too, so there are ways to get it. Now they just tend to be more expensive. So sunscreen is one of those things I say, just buy the cheapest one that fits well, that works well, and sometimes that does mean spending more money to get something that doesn't burn and for that short period of time looks elegant enough that you're still wanting to go out in public and you still are able to do that. So sometimes our patients do choose to spend a little bit more on these more elegant physical blockers during their time that they're having irritation on the skin. So that's kind of, those are the reasons to choose between one or the other. The physical blockers just tend to irritate broken skin less than a chemical. Yes?
So the physical blockers actually, aren't they in a way or another with having zinc inside, aren't they close to the disinfectant that we use
Yes,
with the babies?
yeah, it's a great
that
question.
Really block, it needs a cover.
Yeah. That's a wonderful question. So is the physical blockers containing zinc, is that similar to Desitin at all?
So Desitin can work too?
Absolutely. So Desitin is just a higher concentration of zinc. So actually, Tim knows my son has a recent burn on his chin from a few weeks ago, and I'm trying to sun protect it. And that's exactly what we're using is the baby butt paste zinc oxide. It's, I think, 15%, and he's just got this white chin now because he's 4, it doesn't matter how he looks.
It has 15% on top, like not regular Desitin, but it has some extra and saying that it's sunblocker.
Yeah, it's exactly the same active
Not
ingredient.
regular Desitin. There are certain Desitins that would have a sunblocker.
So Desitin I haven't studied all the Desitins, but Desitin, the main ingredient in there tends to be zinc. So when I went to CVS this weekend and we were looking for zinc, we just went straight to the baby aisle. Desitin also has fragrances and some other things. So if you really truly don't mind the look of that and you're trying to protect, let's say you have a burn on the hand from chemotherapy infusion or something, we're trying to sun protect that, and we don't mind having that white spot there because we just want to heal as fast as possible.
It's not going to stay white.
Yeah, after some time it rubs off.
And it will just look
Exactly.
okay.
Yep, so then that you want to go and you can get you just look for the most generic, purest form of zinc and you'll be able to find it. And so we actually didn't get Desitin, we didn't get A&D, we just went and got the generic zinc oxide, which is just pure. Yep.
But from the same aspect.
And it will protect even more because it has a higher concentration of the actual metal that will block.
These are like extra options.
Yeah, absolutely. So if the skin's
Mothers who got affected.
absolutely, yeah.
Something even in their hand.
Yeah, exactly. That's a great thought. And someone who might be going through radiation where you want to protect from the skin and soothe the skin, zinc is something to think about because it'll give the sun protection and be soothing at the same time. So great question.
Okay, so
Yes.
So that potentially is putting on a moisturizer serum, then putting the zinc, then putting on a foundation over that would do it, right?
So say
I'm
that
sorry.
one more time.
So
Yeah.
I'm just thinking of
What order do we put things on?
things on.
Yeah,
Yeah.
yeah.
That's sort of the thing. Sorry.
Yeah, no. Great question because someone comes to our office, we say put these 5 things on. What order do we put on? So how I like to think about it is if the physician is giving you a prescription cream or medication, we want that to be probably interacting with the skin first. So we don't really want anything under that. So I put medicated ointments and creams or lotions first. That way it's going to do its job. Then on top of that, if someone's wearing makeup or they need sunscreen. So some patients will have just the sunscreen in their makeup. But for most patients, we tell patients to use their sunscreen next. So sunscreen should always go on top of medicated things. Now, when you're trying to figure out where makeup goes on top of that, probably wouldn't be realistic to put the sunscreen on top of the makeup because that would smear it. So the best thing is probably put medicated things on, then put sunscreen, then put makeup on top of that. Does that help?
Unless the
Yes.
medication
Yeah. No.
itself has the sunscreen.
Yeah, and if the makeup has a sunscreen, that's perfect, and we could just use that, and then we're all done. Yep, absolutely. Okay, so my final slide is just any questions that we have, and I just want to thank everybody for your time for coming here and also for sharing your questions and your journeys so that we can all learn from each other. This is our wonderful team here at Stanford where our mission is really only to take care of the skin of patients who are going through or have gone through cancer therapy. So no question is too small, no visit is too trivial to come to our clinics. We just welcome everybody here. Yes, another question.
Barrage of questions.
Yes, absolutely.
Okay, so do you deal with the discoloration of the nail bed?
Absolutely, yeah. Yeah.
The-
Yeah.
No, does it ever go away?
Yeah. So then
And what do I need to do to make
Yeah.
sure it goes away?
For sure. So the question is, do we help with discoloration of the nail bed? Does it go away? So in general, depending on the chemotherapy, there's some chemotherapies that can cause a temporary darkening of the nail. Some of them can actually cause even new moles in patients, and sometimes you develop that mole in your nail that then grows into a streak. So for the most part, if there's just darkening of the nail bed, of that moon of the nail, that's temporary, and usually with time of a few months or up to a year, that fades after discontinuation of therapy. Every once in a while, someone does have an actual mole, which is not darkening, but actually cells that are producing our skin colors and pigment. And that's something that we definitely want to see so that we can monitor, make sure that we don't have a skin cancer. And that probably won't go away, although some do fade. So it kind of depends on what type of pigmentation we're seeing. In terms of what to do to accelerate that fading, so with any pigmentation, we know that UV radiation kind of keeps pigment there or stimulates more, because I think our skins and our melanocytes, which produce pigment, the natural instinct to UV is when you get UV exposure, your body is going to try to protect and shield the DNA of your cells from the radiation. And so that's why it makes more pigment. That's why we get dark. That's why we get tan. It's because we're literally the cells are trying to put an umbrella of pigment to shield the precious DNA from radiation. So anytime someone has an area that's darkened, if we expose it to UV, that automatic response is going to happen, and that's going to prolong that ability for that pigmentation it's going to prolong the time that pigmentation takes to heal. So in anyone who has pigmentation that we're trying to treat or accelerate the decrease of it, we recommend just being wary of UV radiation as much as we can shield from that. We're probably going to shave off days, weeks, months from to recovery there.
So maybe wear gloves?
Yeah, I think wearing gloves.
Because I personally started having that.
Yeah, I think wearing gloves is great because we get a lot of UV from just driving and sitting there, just from coming in from the windshields. So wearing gloves if possible, or just not forgetting the hands as a place to put sunscreen in the morning, although we wash our hands so much more, it's harder to say.
Used to say when you wear white, it reflects, so that's better. So people wear white and light colors in summer. And the dark colors like black, it will absorb the heat.
Yeah.
Now they are coming with a new research saying, no, it's the opposite.
Yeah.
The black is the one that will not allow the heat come in. So wear black gloves will be better than white gloves.
Yeah.
I don't know now.
I know, it's so tricky.
It's
so I think
an opposite idea.
Yeah. If you look at the rating of SPFs of clothing, so what I was saying before is that we don't really need to, when you're walking out, you're not going to be in water. You don't need to buy the expensive UV shirt from whatever company because you're normal clothing. But different shades of clothing do have different SPFs. So if you take a very thin white T-shirt, the SPF of that is going to be a little less than a darker T-shirt. And then definitely if it was wet, that decreases the SPF too. So I think in terms of heat absorbance, it's a little bit different, but actual protection from the UV rays, probably thicker or maybe darker clothing might give you a little bit more, but it's probably more the thickness of the clothing rather than the color.
If I have two pair of gloves, I can go for the black one.
Yeah, you can. Yep, I think it's fine. Unless it feels hot for you and uncomfortable, then I think we like to trust our body's signs and signals to us too. Yeah. Another question? Yeah.
So that go with the face skin too, right? On my first chemo treatment, it turned really red, rash, and then a couple weeks later it turned black, and they not go away.
Yes, absolutely. So the question is, with my chemo treatments, if I develop a rash and I notice that my skin is now dark, even though the redness faded, is that the pigmentation? 100%, absolutely. So anyone with pigment in their skin, which is you, me, actually all of us in this room, anytime there's damage to the skin, whether it be inflammation or something, there's collateral damage to the melanocytes, and then you get a leakage of the pigment. So that's what's happening here. And as the rash fades or gets better, it leaves this darkening. We call it post-inflammatory hyperpigmentation. And absolutely, sun protection is so critical there in order to accelerate that healing, because otherwise it's that darkening, it's so visual, it's there, it will get darker with more UV exposure. So in order to accelerate that healing, absolutely, sun protection is so critical and important and will be helpful.
So is there any lotion or can improve the skin tone?
Yeah, it's a great question. So I think definitely with your future cycles of therapy, it's just if we can prevent the damage, then we can prevent the pigmentation. So I think getting ahead of our chemotherapy reactions is very important. So if for patients that are on specific therapies, sometimes we like to meet them as early, or not sometimes, we always want to meet everybody if they can as early as possible, because there's more likely than not some knowledge that is out there already about what will or can happen to your skin with your specific therapy. And then if we can help prevent it, then we don't even have to deal with the hyperpigmentation. So for patients, for example, on the taxane therapies, we know that it's very common to get rashes on the tops of the hands, the face. So if we can give our patients tools to prevent them or the tools to treat it when it's there early, then there's less of the pigmentation that they have to suffer with later. That being said, we do meet patients kind of later or after their treatment, and we love and would love to help too. I think for pigmentation, the sun protection is critical. No matter what we do, if we don't do it with sun protection, we're going to have a hard time healing there. And after a few months or longer, if things aren't getting better, there are prescription bleaching creams that can be helpful. They're not perfect. They tend not to be covered by insurance companies, so it costs a bit, but there are options that we can help in the long term if it's not fading.
After the chemo.
After chemo treatment. But I think the best thing to do is to prevent further damage, because every cycle will cause more, and it's just going to be a more difficult thing to treat later. Yeah.
May I make
Yes.
a quick suggestion?
Yeah.
We have our parents, like, old remedies, like
Yeah.
to add yogurt to some squeeze of lemon and
Right.
some honey or some starch, or you can make
Right.
two kinds of masks.
Yeah.
And like you put it around your face, if you are talking the face, wherever the pigmentation is, for
Yeah.
like 10 minutes or so.
Right.
Then until it's dry, then you just feel it, and then you call, and then it's kind of
Yeah.
unify the color. Or,
Right.
I mean, does this conflict with having the chemo? Would
Right.
that affect it? Like if I dare to do such a
Yeah,
thing, would
I
that
think
be bad?
we just want to be so careful. So the question is, our parents' home remedies of, lemon or other things that we use on our face, do we dare to use them? Are they going to be helpful? I think it's always so tricky. I think going through cancer therapy, as you all have experienced or are experiencing, it's a very unique time where we try so hard not to introduce any additional complications that don't need to be there. And then when we are trying to limit potential complications when there's unknown, that introduces that risk. So I'm a very risk-averse person. So I think with our patients, it just breaks my heart if I do something that causes them more harm or damage than before. So I love to work with what we know, which might come at the expense of sometimes not being able to suggest something that actually could be helpful. So, but we do, so I think there's a big job for us to keep trying to know and learn more. But at the same time, those are things that because they're so not studied or we don't know, there comes that risk. And for some patients, they might be willing to take that risk, but we would love to share the things that we know that have been studied and tried.
Things are proven.
And then the patient can then be empowered to choose, and it's okay to choose anyway, either way there. But I think it brings up a great point. There are a lot of things that we don't know yet that are probably going to be tremendously helpful, and part of our job is to continue to push and ask and learn from those who've experienced it, so we can share what works with future patients as well. Do you have another question?
It has to do with lymphedema.
Yeah.
And how the body reacts as well.
Yeah.
Are there, I guess, any guidelines? Because the skin, I understand the discoloration that occurs in lymphedema. It's like that lower extremity lymphedema.
Yeah.
Is there based on, is there help?
Is there help? Yeah, for sure. So the question is lymphedema, it causes color change in the skin, especially on the lower extremities. Is there any way to help? So I think that's another one of those things where I like to step back and think, do we know, have we worked up everything that has caused the lymphedema? And if we haven't, let's make sure that even though we're chalking it all up to this, let's make sure that that's accurate, that we've looked at every single thing, make sure it's not due to a cardiac problem, a renal kidney problem, a lung problem. And that way we can discover anything that could reverse that first domino that's causing all those other things. And then if we've looked at all that and in the end we just realize this is just going to be a chronic problem forever and there's nothing that we can do to reverse the edema, then we can work on that next step of how can we then manage what we have here. So first we want to make sure there's no reversible medical situation such as a drug or any organ dysfunction that's leading to the edema. Once that's been done, most people that's already been done, then what are the measures that we can take? So the pigmentation that happens is because the skin is like this balloon that is being stretched, and then everything there, also the blood vessels, the lymph, everything, every keratinocyte of the skin is being stretched and irritated, and then that's causing the leakage of blood, of pigmentation that then gets trapped in the skin and takes months to years for the body's immune system to eat up and make disappear. But even though it's trying to eat it up and disappear, the edema is still there, so it's causing new damage. And so that's why it stays with patients for so long until we can get rid of the edema. So our approach in those situations are twofold. One, we again want to reverse any causes of edema, but if we can't, then we use things like compression stockings, elevation, things that are trying to push the fluid away from the leg so that we're taking that tension off. So I'm a big fan of compression stockings through the day to keep the fluid off, and then elevation as much as possible above the level of the heart to return. And that way we can stop that cycle of constant damage so that we can get a better chance of healing those secondary changes like the rash, the itch, the pigmentation. Now when we have the pigmentation there, I think that's a time thing. And so with time, if we have the edema under control, whether it be medically or through elevation and compression, then with time, I think the body's own immune system is going to finally eat up all those, that hemosiderin, so it's like products of the blood that have leaked out, the pigmentation that's been there, and sun protection would help too at that time. But it can be so tricky because the lower legs are, because of gravity, they're constantly getting hammered every day from just swelling because everything just sinks toward the legs. So I think that pigmentation's hard to treat until we can get the edema under control. People get a lot of edema also, a lot of pigmentation from developing a dermatitis, so an itchy rash. Sometimes you can't see or you can't feel that it's itchy, but you see a visible kind of reddish rash, and that can lead to pigmentation. So if we can stop that using sometimes a prescription topical steroid and calm that injury, then that'll lead to less of the pigmentation as well.
I developed the reason I'm asking the question, I wear my compression. I
Yeah.
have to take them, actually they have to stop wearing them
Yeah.
because the skin changed. So
Because it would.
because they thought some edema had developed because it was starting to discolor.
Oh.
I live in my compression garments.
Yeah.
They're my
So the recommendation was to remove them because of the color change.
yes.
Interesting. So.
Because they felt that was the only thing that they could understand.
Yeah.
Because everything else is under control, the swelling, everything.
Yeah.
And so to take a break for a week,
Yeah.
and put them back on,
Yeah.
start wearing them regularly again.
Did that help? Or
Not yet.
Not yet, right? I don't know if you see a dermatologist, we'd love to help set you up with it, just to take a peek, because we can maybe tell where I'm thinking that maybe the thought process there is that the pigmentation that or the discoloration you're seeing is due to maybe the compression, like popping a blood vessel and causing that. So which can happen. We've seen patients with massive bruises because the compression's so strong, and then it causes that look. So there's this delicate balance sometimes. But I'd love for someone to take a look at, just to see if we can kind of pinpoint where is this pigment, because pigmentation can be from so many different sources, just to give a better idea of whether or not we think it's from the external trauma.
Yeah, I thought it was just me, but then of course I found a fellow person who had also wearing compression, and it was hers were arms. And she says, "Oh yeah, I got the same." Of it. Oh God, thanks not me.
Yeah.
So I think there is an issue with the compression garments having to wear them all the time and being very diligent, like washing your hands.
Yeah.
There's this other kind of flip side that your body still is your body and it has a reaction.
And it doesn't like that tightness, right?
After a while,
Yeah.
it's,
Mhm.
I mean, it's not
Yeah.
like it happened immediately, like
It was a year wearing them,
Right,
and all of a sudden
right.
this thing
Yeah.
developed.
Right.
So that's what I wanted
Right.
to find out from.
So interesting. Yeah.
Yeah. Okay.
Yeah. Definitely,
So-
you're right. It's like not a natural situation.
Yeah, because everything's compressed and dark.
Yeah, absolutely. Any other questions? Yes, please.
Two-part question.
Yes.
Number one, how do we get referred to dermatology,
Yeah.
and by which
Right,
doctor?
by which doctor, yes.
And then number two is, where is the dermatology located? Because I normally go to South
South
Bay.
Bay, excellent. So question is, do we get referred? And then two is, where are we located? So thank you for asking. I should have had our clinic phone number here. So absolutely, please don't hesitate to ask your oncologist, your nurse practitioner, your nurse coordinator, any member of your team, and let them know that you would be interested in a referral to dermatology. So we're called the supportive Dermato-Oncology, but it's still part of dermatology. And clinic and program, and we're based out of the Cancer Center in Palo Alto, but our Stanford Dermatology Department is, we have more than 40 of us here all through the Bay Area, and we understand that patients can't all travel to Palo Alto, traffic, distance, so actually we will have a presence in the near future in the South Bay Cancer Center, but we also do have dermatology satellite sites in Los Gatos, San Jose, Santa Clara, Los Altos, East Bay, San Francisco, or Emeryville, and all through Palo Alto, Redwood City. So we can find something that works for you. Many patients, because they want, and they and their oncologists kind of may desire that care from our specific program. We see a lot of our patients at least one time, and then we bridge them to somebody locally, and we can partner together. And then you also know that we're available for you in any urgent need or any urgent capacity, and we're happy to work with your oncologist. Many of our patients, we work hard to get them seen in our clinics the same day they travel to Palo Alto for an infusion or for a visit with their oncologist up there. So we want to, I think part of our program here is not just because we try to gain expertise in these specific skin conditions that happen, but we also want to, we are devoted to trying to understand all the logistical issues that are coming when you're trying to balance all of your different care. We are lucky enough to be housed in the Cancer Center, so we can try to make it as practical as possible and just as smooth as it possibly could be to add another physician to your list. So I would ask your oncologist, if they don't know about us yet, please don't hesitate to share my email address or name, and I'm so happy to speak with them and figure out how we can get you some expert care, and eventually we hope to be in the South Bay soon. Yeah.
So, are you an 875 takeover?
We're at 900.
We're at 900.
Yeah, we're at 900. Yeah. Any other questions? Okay, thank you all so much for your time and your wonderful questions. Yeah.